Good afternoon, everyone, and welcome to today's Children and Family Treatment and Support Services Billing and UM Office Hour. Today's office hour will be referring to the other licensed practitioner, psychosocial rehabilitation, and community psychiatric supports and treatment services. Before we get started, we just want to go through a few logistics. The slides and recording will be posted to ctacny.org. The slides and recording from last week's billing update webinar have been posted if you want to look at those. We also want to remind everyone to submit questions via the chat. So just if the chat is not already open, you can, on your right side panel, you can open it by clicking the little thought bubble on the bottom of your screen. And please submit all questions to the host and panelists, and that way we will be able to address them. We also just want to remind everyone that information and timelines are current as of the day of this webinar. So we're going to start with a brief presentation. We're just going to talk about the overview as well as billing and UM concepts, as well as some frequently asked questions and answers that we've received for billing and for utilization management. And then we're going to open it up to Q&A, so just submit any of your questions via the chat. And with that, I'm going to turn it over to Boris.
Great. Thank you, Caitlin. And again, just wanted to underscore that today's webinar is really meant for folks to submit their questions, and that's why we refer to this as office hours. I really would appreciate that, and feel free to submit them through the chat throughout this presentation. So again, now just doing a quick foundational, basic kind of information here, just to make sure we're on the same page. I wanted to remind everybody about the timelines. The three services that Caitlin just mentioned are going live on January 1st of 2019, followed by additional CFTSS services with family peer support going live in July, youth peer support and training in January of 2020, and crisis intervention on January 1st, 2020. Again, the billing manuals and rates are posted. When the slides become available, you'll be able to access them through the links that we have here. So we just wanted to remind folks that those manuals and rates are available. And as another reminder, the providers must be designated to provide the services we're talking about. Also, all the providers must enroll as a Medicaid provider in order to get paid. And for the Medicaid managed care plans, of course, providers must be contracted and credentialed with that plan to be able to bill and provide services to the members of that plan. And it is critical that providers claim test with the plans to prevent potential claiming and payment issues. So again, we'll say that multiple times probably throughout this presentation and discussion, so please remember to claim test. With the Medicaid managed care plan network requirements, managed care are required to have full networks that ensures, access to the individuals who are need these services and seeking for these services. A Medicaid managed care plan will deny claims for unauthorized services. So when we talk about utilization management, especially, it's important to keep that in mind. And except for newly carved in exception for newly carved in services, I'm sorry about that. If a provider is delivering the services to the enrollee prior to the implementation, so this is about the transitional piece here, we want to make sure folks understand that the plans must allow providers to continue to treat an enrollee for current behavioral health episode of care, even as an out-of-network. So even if you don't have a contract with the plan during this transition period, the plan must allow the individual to continue with you for up to 24 months. But of course, you will need to work out a single case agreement with that plan to be able to receive payment for those services. But again, there is this continuity of care requirement, and just wanted to remind folks of that requirement. So some other basic information, just making sure we're all on the same page here. Wanted to make sure folks understand what utilization management is. So just a definition, it is a procedure used to monitor and evaluate clinical necessity, appropriateness, efficacy, or efficiency of behavioral health services, procedures, and so forth. So it is a process and a procedure of monitoring this, and the designated providers must have the ability to bill fee-for-service and managed care. So as we go through the utilization management, that leads to authorization. It's important to remember that you will be serving individuals who are both who are enrolled in managed care, but also might still be straight Medicaid, and you'll be billing fee-for-service directly for those individuals. So types of authorization reviews, the ones that are really most common are the pre-services of prior authorization. It's important to point out for the OLP, CPST, and PSR, there will not be any required pre-authorization, but it is still necessary and important to notify the plan. So even though you do not have to obtain prior authorization, it is important to be in communication with the plan about their members and make sure they understand that you will be starting those services with them. Concurrent review, on the other hand, could be required by the plan, and of course occurs as an ongoing component. And the state is looking to standardize the process via a general form. So more information on that to come. So again, as I mentioned, the standardized concurrent review request form is being worked on. So some of the creation process and release timelines are working through some of the small work groups of plans and providers, and we'll be sharing information with stakeholders soon. And of course, as given, the form is really meant to ensure consistency across providers and plans to avoid any delays or confusion. Key points as we talk about the transition into CFTSS, just to highlight. So the Medicaid managed care plans may not conduct utilization management or require service authorization for the period of 90 days from the implementation date. So here we're talking about January 1st. So what does that mean? So for OLP, CPST, and PSR, there will be no utilization management until 4/1/19. And additionally, Medicaid managed care plans are required to offer contracts to all providers. So please make sure that if you have received a contract, that you review that and communicate that. And if you have not received any contracts, please feel free to reach out to the plan and start those conversations and start that process. If you're not sure who to call or how to contact your plan, please refer to the Matrix tool that we have on our MixTAC website that will provide you information with all the contact info on all of the plans. So some of the key points around billing. One, as we recently did the billing webinar, one of the key questions that came up before then was what the rates downstate versus upstate, what constitutes downstate versus upstate. So we wanted to, again, remind folks that information has been provided, and just reminding folks that the downstate includes the 5 boroughs of New York City, Nassau, Suffolk, Westchester, Rockland, Putnam, Orange, Ulster, Dutchess, and Sullivan. And then all of the other counties would fall into the rest of the state or the upstate billing. And so when you look at the rates in the links that we provided, that's how you should consider that. And one of the important pieces is when you do consider billing managed care versus billing fee-for-service, again, if the child is enrolled in the managed care plan, the services for CPST authorized should be billed directly to managed care. Also, the waiver services, the crosswalk to the 3 CFTSS services must be billed as of January 1st under the CFTSS component. There is an exception for children who are SSI or will be receiving services through fee-for-service Medicaid until July 1st. So again, on January 1st, the three services go live if a child is enrolled in Medicaid managed care, but it is designated or is determined to have SSI. Until July of next year, you will continue billing Medicaid directly. That information is available on ePaces or InMedNy, and so make sure you keep track of that and know that. And if you do come across these situations until July, you will be billing Medicaid, even for kids enrolled in managed care. The information around treatment plans, medical necessity, and assessment for children transitioning to waiver. Again, so we want to make sure that this transition goes as smoothly as possible. So in order for the transition to go smoothly and quickly, waiver to corresponding CFTSS going live, the HCBS plan of care can temporarily serve as the required treatment plan. However, the provider will be responsible for securing recommendations from the licensed practitioner of healing arts for the new CFTSS as required in the service manual, and that recommendation needs to happen no later than January 18th of 2019. And the provider will have until March 31st to develop the required treatment plan for the services. Again, recommendation and assessment for the new three CFTSS can occur as early as today. So we highlighted that. That's one of the big questions we got. When can we start doing these recommendations and assessments? And you literally can start doing this as of today. So as Caitlin mentioned, as part of our agenda, we do want to kick off the Q&A portion with this, with some of the questions we already received and some of the answers we have. So first, we'll start with our billing FAQ component and some of the questions and answers we already have. So one of the questions.
Boris?
Yes.
I'm sorry to interrupt, but before we move forward, there is a comment here at the Office of Mental Health, so we just want to give an opportunity for Alyssa to make a comment.
Yeah, before you get into the FAQs, Boris, we just wanted to acknowledge that the last webinar that we had that was devoted to billing the three CFTSS going live in January, and some of the questions that are coming in through the chat box today are related to the issue around off-site billing and the units and how those are billed. So there was some discussion about that at the last webinar, and we just wanted to, before folks continue to ask questions on this topic, we wanted to let you guys know that we acknowledge that there's a lot of confusion around this issue, and at the state we're going to be reviewing the current guidance to make sure that the guidance is accurate and that we get you guys clarifying information. So we're not going to be addressing that today because we want to look into it further, but we will be getting information out as soon as we can.
Excellent. Thank you. But we do have questions and answers to other pieces of this transition. So thank you, Alyssa, for the offsite piece that we do want to go through, and questions. We do have other questions as well that we would going to try to cover today. So as I mentioned, some of the questions that we got was if a claim is submitted with number of units that exceed the maximum allowable units, will the plan deny? And the answer is yes. The plan will most likely deny, the units that are exceeded. So I think it's important to note that. So again, if you go back to the services and the manuals, it clearly specifies the maximum number of units. So that's in reference of what happens if more than maximum happens. What makes a service offsite is anything beyond administrative side office. Answer: offsite services are intended to be provided in the child's home or community. All office locations, including satellites, are considered to be on site. Another question we got was for services provided to a group offsite, can you bill for offsite for each group member even though the group is obviously provided in one location? And the answer is yes, you bill the offsite for each member of the group. A couple of more questions regarding billing, and then we'll move into utilization management questions. Since two separate claims are required for off-site, does the provider have to wait for the service rate claim to process before submitting the off-site rate code? And the answer is the provider does not need to wait for the service rate claim to process before submitting the off-site. So again, there is no need to wait for that, and they could be submitted at the same time. And if off-site is billed with two claims and both include the same procedure code, will this not look like both on-site and off-site services were provided on the same day? And the answer is there is actually a differentiated piece to it, and those are the modifiers. And we have a couple of examples where it might seem that it's going to duplicate, but if you add, which you should be adding modifiers to all of the services you're billing as per the manual that was provided, there is a differential. So in this particular case, the SC provides the difference between two of these. So there is a way to determine and indicate that this is not the same service. Under the UM, or Utilization Management, questions that we got, are you anticipating issues with the plans denying coverage, excuse me, if notification of the first three visits is not received either on a timely basis or at all? And the answer is, even though prior is not required, it is still necessary for providers to notify the plan that they will provide services to the child. And I can't kind of emphasize enough that this is an important piece for many different reasons. And one of them is to even find out if the individual, the family, is potentially receiving these services from another provider. And you might not be aware of that. And so it's important to always communicate with the plans and make sure that you're in touch with them even when authorization is not required. Is the first 30 visit authorized per CFT, or is the 30 visit inclusive of all services? So the 30 visits have to be conducted in a certain time period. And so the answer for that is, upon concurrent review, any authorization must be for at least 30 visits for each individual service that the child is receiving. So if the child is receiving OLP, CPST, and PSR, they get 30 visits for each. There is no set time period. Those visits must be conducted in. Next question on utilization management. Is the 90 days of service before authorization is needed guaranteed for every child who is recommended for service, or only those that are being serviced on the day of one of the service becoming available? So answer. For OLP, CPST, and PSR, no utilization management will be conducted for the period of 1/1/19 through 3/31/19. Beginning April 1st, 2019, the plans may conduct concurrent review for these services. So again, as we just went over, for those 3 months, there'll be no utilization management. Another question that we got was, will there be a standard form for the treatment plan for the assessment to determine medical necessity for each service? And the answer is there will not be a standard treatment plan, but there will be a standard form for the authorization request, as I've mentioned during the presentation. And so the state is working on that, and we'll be distributing this form in the near future. One more question we have here. For children currently enrolled in waiver services, is there a different authorization period? Is it still the case that children will be authorized for 6 months after go live for any services they're currently receiving? It's a long answer, but I think it's worth actually reading and making sure folks understand. We have gotten quite a few questions around this. So the answer is the 6 months provision refers to the time period for which the plan must continue to authorize the child existing plan of care for kids in HCBS waiver from the date that the child transitioned to managed care, which includes some services that crosswalks to new CFTSS. For example, if a child is receiving skill building through the OMH or OCFS 1915C waiver, the child will have authorization to continue to receive PSR for 6 months after the transition to managed care, because skill building will not be provided and built under PSR. This is in addition to the 90-day period for which the plan may not conduct utilization management for the date of service, date a service comes into the managed care benefit package. So hopefully that provides more information and clarity as it relates for the children that are transitioning from the waiver to CFTSS. We're also going to include some of the resources and links. I'm not going to go through these, but these will be available, again, when we make the slides available on our website. So please make sure to take advantage. Here's the matrix that I've talked about earlier in case you're not sure who to contact at managed care, especially around contracting and credentialing. We also have a billing tool. Just wanted to remind folks that are interactive. So if you have any questions regarding what might go into a particular field, please take advantage of the billing tool. And I think now we just want to pass this along to our discussion and questions from you folks. So I'll pass this now to our friends and partners in Albany.
Hello, Boris. Yes, thank you. We do have a number of questions coming in. And so there's a lot of questions that have to deal with the off-site locations. And so the question is, what is considered off-site in terms of service delivery?
So an off-site location would be a location that is not at the actual office. So an example of this for a group service could be a community center, it could be the school, wherever you might be able to convene that group in the community.
All right. And I know that one of the slides really kind of addressed that earlier in terms of what is considered off-site in terms of service delivery. There's some questions around EBPs, and the question is, can an EBP like family functional therapy or functional family therapy, be provided under OLP?
So just to be clear, the state has not yet developed specific EBP rates or a list of state endorsed EBPs under the Medicaid redesign. So that process will take place. It just hasn't been completed yet, and it's pending for the near future. However, if for some reason you have an EBP in your organization and you have licensed practitioners that meet the qualifications and the services that you're providing are adherent and compliant with those as outlined in the state plan manual, and you're providing services as recommended by a licensed practitioner of the healing arts, then you can provide the service. And if it adheres to those criteria and it's under functional family therapy, then you can provide that service under OLP or CPST, depending on the staff qualifications and the mode of the service that you're providing.
There's a question around HCBS providers as they bill Medicaid managed care for the new children and family treatment support services. The question is, are they required to submit plans of care to the managed care organizations? The answer to that would be yes. Thank you for that question. It's very helpful. So in order, just like has been talked about in all of the and billing guidance presentations, to date, the managed care plan will need to be notified that you're starting to provide services that you're going to be billing them for, so they can make sure that you can claim to them that it's enabled in their systems, right? So that you want to notify the managed care plans that you're going to be providing services that you're going to be billing them for. So for those children who are in managed care and whom you are providing CFTSS services for starting in January, you will need to notify the managed care plans that you're going to be providing those services.
And I'll just add that it wouldn't necessarily be the plan of care that you're submitting to the MCO. It would just be a notification at that point that you are going to be billing for those services. As a reminder, there is no for the three services for the first 90 days, but we just want to make sure that when you do submit the claim, the managed care plan had a heads up so that they were able to open up that authorization and make sure that there's no administrative denial when the provider submits the claim. The plan of care, there are some additional requirements about what needs to be submitted in the plan of care for children receiving HCBS. However, because some of those services are transitioning to CFTSS, there are different requirements around CFTSS, and that is that a treatment plan is developed And as we've been talking about with you all, it isn't necessary that the providers submit the full treatment plan to the managed care plan. We're going to be developing a standard form for folks to submit the clinical information that's necessary to the managed care plan when the time does come that they need to request concurrent review.
So here's my question to you, Alyssa. If it happens to be that these are transitioning HCBS children, and these are services that were previously HCBS, so they're initially putting them on their plan of care because that's what they're going to do initially until they are able to develop a treatment plan. Those services that are provided under that circumstance in which they are now providing CFTS, those are 180 days of service provision, correct? Not 90.
Right, but
so would it behoove the waiver provider to notify the plan that these are transitioning waiver kids and these services are on their plan of care?
Yeah, I mean, I think that's totally fine. They should notify the managed care plan, but the requirement around the plan of care doesn't go into effect until the HCBS services are in managed care. So the 180-day requirement does not even kick in until April.
Great.
So, like we had said in the like Boris had mentioned in the previous slide, that 180 days for no to their plan of care begins in April for children who are already enrolled in managed care, and for those who are transitioning to managed care who are not currently in managed care today, that 180 days begins from the date that they enroll in managed care. So we are trying to work through an easier way to kind of understand all of these continuity of care requirements, and we're developing a tool that's going to help folks with that, both the plans and the providers and families, to understand those requirements. But there is no requirement that a plan of care is submitted for the CFTSS in January.
Thank you. That's very helpful.
Thank you. All right, so there is a question around, someone wants some clarity around if an HCBS waiver recipient is going to receive the comparable children and family treatment support services. The question is, do they just need a recommendation by the LPHA and not an additional assessment?
So the LPHA making the recommendation should be treating or assessing licensed practitioner of the healing arts. So assuming that they're engaged in treatment or that LPHA is serving them in some way, shape, or form and knows that child enough to verify medical necessity and make the recommendation, then there's no need for any additional assessment to be completed if it's a treating practitioner. If the LPHA doesn't know the child, isn't treating them actively, but they're utilizing the LPHA to make the medical necessity, then that LPHA would likely have to do an assessment in order to get to know the child enough to make a recommendation based on their learning of the medical need of the child.
Okay, thank you. And if they start the eval today for recommendations, the question is, how do you bill for that?
So that's a good question. So again, if they're a treating practitioner, likely they could get reimbursement for that activity as part of their ongoing treatment and services. But if they're utilizing a internal LPHA that they're just using for the purposes of a recommendation and an assessment, it may be that they're not able to get reimbursed for that assessment.
Okay. And is there any guidance regarding if an OLP can be an independent contractor within an approved organization, so within a designated organization, or do they have to be an employee?
So I think an independent contractor, although maybe not an employee, is employed by the organization. So I think we're mincing words here. But if they do engage in a non-physician licensed behavioral health practitioner who is going to be providing other licensed practitioner services for the agency by a contract, that practitioner would still need to adhere to all of the requirements as outlined in the manual and as required by the agency. So any background check requirements, any particular training requirements, any documentation and such requirements, any supervision requirements, whatever it is that is required of the OLP service and the practitioner providing those services is still in place and must be adhered to by the agency contracting for that person.
Okay. There's a few questions around billing. This question is, if an agency's IT infrastructure is not fully in place for billing beginning on January 1st, can claims be backdated for a period of time?
When billing managed care, you would be expected to adhere to the contractual timely filing guidelines with the managed care organization, which is a minimum of 90 days. You would bill with the appropriate date of service on the claim. If you happen to bill after the date of service and you put that correct date of service on it, that is fine. We would recommend, though, that if your system is not quite ready to bill electronically, you could submit paper claims to the managed care organizations as well, as they are expected to accept them.
And just in addition to that, the state is going to be sending out just a reminder to providers who have applied or been designated for services that if they are designated for a service that's going live on January 1st and they aren't ready to provide the service, or they're not going to be able to bill for that service within the time frame in which they're required to submit claims, they need to contact the state, and we would be temporarily de-designating them and then allowing them to reapply when they're ready. All of the information stays in our system, but we need to make sure that we have accurate lists of designated providers to avoid some of the challenges that we experienced through the adult implementation, where we had a lot of providers that were out there as designated providers that weren't actually ready to provide services, and they had to turn down referrals, so it kind of created some access issues for the adult HCBS implementation. So in an effort to avoid that, we just want to make sure that our designation list is reflective of those providers who are actually ready to go. And if you're not, you can reapply as soon as you are ready. We have a rolling review and designation process. So we have confidence that if you're not ready initially and need to be de-designated, that when you are ready, we can get you back up pretty quickly. Okay. There's some questions here related to the evaluation and assessment for the new CFTSS services. So the question is, what is the evaluation assessment tool that needs to be used by the LPHA?
I would say that the tools and ways in which they assess children within their scope of practice should be used. I think that it's up to the licensed practitioner to determine that. We're not being prescriptive or directing people to a particular tool.
Thank you. And for clarity, there's a question around having the LPHA complete a recommendation for all enrolled HCBS clients by January 18, 2019. Is that correct?
I'm sorry, can you repeat the question? I'm not typing it.
Yes. To clarify, so in this transition, all of the waiver kids need to be crosswalked to the new CFTSS services. And what is the timeline for that? I believe the timeline is they need to be transitioned by January.
Yes, January 18th. Absolutely.
For the 3 that are going live in January.
Yeah, for any comparable services that they're receiving in the HCBS that are crosswalked exactly. They need to be transitioned by January 18th of 2019, and to do that, they need an LPHA recommendation and those new services to be listed in their plan of care.
There's questions around notifying the MCO, so I'll just kind of lump a couple questions together. So is there a standard form for notifying the MCO? And there's a question around please define notification. Okay. So notification can be picking up the phone and calling the MCO. There's no form needed. You would just want to get in contact with somebody at the plan so that they understand that you're going to start serving one of their children and that you'll be submitting a claim for that service. So notification is different than authorization. Notification is just literally notifying them, letting them know that you are going to start services. You're not asking for permission. You're not submitting any clinical information. You're just letting them know. And we would be happy to issue a definition for notification in some of the upcoming materials. Okay. There's a question around PAR approvals. So someone is wanting to know if there's any more information around PAR approvals for non-OMH licensed organizations.
Yes, we're hoping that there will be information available very soon on that topic. So keep eyes and ears open, and we'll be sure to notify providers. If by chance you currently have received a designation letter in which your designation letter reflected a pending licensure service, what we are planning to do is, when we do have more information, to be sending an email out through the portal, the provider designation portal, to specifically those providers who have a pending licensure designation, so that we would notify them when we would be sharing that information and they would get it directly. So, eyes and ears open, hopefully soon.
Okay. I'm just looking through. There's a question around claims testing. I want to know if there's a deadline for claims testing. They've heard that perhaps that deadline might be November 30th.
The managed care organizations have been instructed to open up claims testing no later than December 1st, 2018. That is opening up claims testing. So I'm not sure what exactly is meant by deadline, but they should be open no later than December 1st.
And if folks are hearing of any specific instances in which plans are providing a deadline for claims testing, we would appreciate that you email the OMH Managed Care mailbox, which is omh-managed-care@omh.ny.gov, and we can help you out. Okay. There is a question around foster care. I don't know who might be best suited or, okay.
Not in the room right now.
Yeah, okay. Give us a few seconds. I'm just trying to read all of the questions coming in. Okay, so here's a question. Can you confirm that to prepare for transition, providers can begin assessments and evaluations of current HCBS waiver children, that it can begin now through the Children and Family Treatment Support Service dates of service that will not be more than 30 days later and before the services are officially added to the state Medicaid plan? So I guess the question is, how far in advance can they be preparing for the transition of those services?
You know, I think that they should be preparing as soon as possible. The reality is we're coming up on Thanksgiving, and then we're going to hit the holidays. There's not much time really to get all your ducks in a row for the number of children that some of the agencies serve. So I would say certainly do that as sooner than later. These are HCBS waiver kids. They not only meet medical necessity, they meet level of care. So I don't think there's a question as to whether they would qualify. So I think documentation that's even secured tomorrow would be relevant and appropriate for services that are going to be provided come January.
Okay, thank you. Questions around conflict of interest. So I know that we've spoken about this before, but the question is there a conflict of interest if the LPHA does an assessment and recommendation for kids they will provide supervision for?
So the conflict of interest requirements that we have within the state are really very specific to care management and the provision of HCBS services. So when we talk about firewalls and mitigations and strategies and conflict of interest requirements, it's really related to what's called the HCBS rule, which is specific to home and community-based services. So those things aren't applicable or relevant to state plan services, which are the CFTSS services. So there is no concern of conflict of interest in regards to that HCBS rule for these services. It doesn't apply.
And to go beyond that, I think in many cases the LPHA making the recommendation could in fact be providing services.
Well, I hope they're providing services.
Exactly. That's the
thing.
Have to be,
right. They have to be a treating or assessing clinician or LPHA.
But they could be providing services to that same child.
Oh, sure.
Exactly.
Yeah.
Yep. Perfect. There's a question around whether or not a provider will need to register. I'm sorry, my screen is if an agency is already an enrolled Medicaid provider, do they need to specifically enroll with Medicaid for the Children and Family Treatment Support Services? If you're already an enrolled Medicaid provider, we would be adding that category of service to your existing Medicaid ID so that you can bill for those services.
Right, which means that you don't need to enroll again as a Medicaid provider. Correct. It just means that we need to make sure that the categories of service are added to your agency so that you can bill, right? So it doesn't require another enrollment.
Okay. Is there a possibility that these three services will be delayed if CMS has not finalized their approval yet? At this point, we have full confidence that we will be launching these 3 services in January. Okay. If an agency has an Article 31 clinic and will be providing SPA services or the new Children and Family Treatment Support Services, if a child is determined to need psychiatric assessment and possibly ongoing medication, how is this billed?
So for psychiatric assessment and psychiatric services with a psychiatrist, that was seemingly very duplicative, but and medication management, the child can be enrolled in the clinic and also concurrently receive state plan services. That so there's no restriction. I couldn't think of the word. Sorry, restriction on being concurrently enrolled in clinic and receiving the new CFTSS services. What I would say, though, is that the services need to be different, and they need to be provided, to be addressing different aspects of the child's needs. They should not be duplicative in any way. But obviously, psychiatric assessment or medication management would not be services that are able to be accessed or provided under the CFTSS services, so that's completely appropriate.
There's a question around licensure and who has the ability and authority to sign off on services. So the question is they have an LMSW that could complete the assessment and recommend CFTS services. The question is, could their LMHC sign off on these, or does it have to be an LCSW?
An LMHC and an LCSW and an MSW under the supervision of, I think, are all recognized licensed practitioners of the healing arts for the recommendation of CFTSS services. For a listing of licensed practitioners of the healing arts that are able to recommend for the services, please refer to the CFTSS manual that's on the Department of Health website, and they'll give you a list. It's quite extensive, and all of those practitioner categories are included, as you know.
Okay. So it seems like we have a number of questions. We're just going to take a moment while we organize and make sure that we're able to answer as many questions as possible. All right, so we have a question here regarding whether or not there's a rate code for OLP offsite.
Yeah, for OLP complex care offsite, the Crisis Complex Care, OLP, is a service that would be provided by telephone. As such, there is just one rate code for OLP Crisis Complex Care, and it's listed as 7904, and that is listed in the billing manual.
If there's a crisis service that you would be providing offsite, you would bill for crisis offsite.
Correct, and the crisis offsite is its own code.
Correct.
The complex care follow-up is unique, and it does state that it's provided by telephone. So, thank you, Meredith.
Thank you, John.
There's a question around clarifying the definition around the modifiers. Yep, so the modifiers, there is a link that we will provide in the FAQ that will show you how each of the modifiers is defined. And then there was a question about, do we bill both modifiers? In any case where there's more than one modifier, you would include all of those modifiers on the claim, and it does not matter which order the modifiers are in.
There's a question around documentation and progress notes. Is there a time frame that progress notes are required from the date of service for OMIG and managed care compliance? So in terms of progress notes, they should really be completed contemporaneously with the service provision. So as soon as possible. I know that it would be concerning if when auditors came in, they found out that progress notes were not written at the time of service. So while there's no specific timeline requirement, it is expected that the notes be completed in a timely fashion.
Typical with any Medicaid reimbursable service, or any service, really.
Here's a question about, Meredith, just looking for a little clarification. It said that you mentioned that the licensed person should know the children, but the reality is for some agencies we need to hire licensed people to provide this service, and they wouldn't know them. I don't see it in the billing manual or in the CFTSS manual. Is this a new requirement to bill for the service? Requirement meaning like that you have to, in order to make a recommendation. I guess the question really is,
how
well do you have to know the child?
I mean, they said that know the child. So I said treating or assessing.
Yeah.
So either you're a current treating practitioner and you know the child, or you have completed an assessment to discern medical necessity.
Yeah.
It's not as though you can, the child can walk in the room, you can shake their hand and say, oh, yeah. I'm going to sign this LPHA recommendation based on, my seeing you. It has to be either based on an assessment or based on the fact that you're already treating them. So no, it doesn't mean that they, so when I said that know the child, I mean based on those two categories of.
And the assessment is an assessment that you choose based on your professional knowledge and scope of practice.
Right, they're all pretty much licensed practitioners. They have standard tools that generally they use.
And there was also someone seeking some further clarification, backing up to the comment regarding an Article 31 clinic providing psychiatric services. Within the clinic, the child would still need to be linked with a counselor in order to receive medical management. Is that correct?
That's my understanding of how it often works in the clinic, is that they get assigned a therapist in order to access a psychiatric assessment and medication. I'll be honest, that's clinic. I don't know exactly the nuances of that, but that's definitely what I've heard. And I think that was actually one of the impetuses for us to remove the restriction, because we acknowledge that access to a psychiatrist and medication management is often integral for kids with mental health needs. So we certainly didn't want to create a barrier to that.
Okay. There's a question around here around the 30-visit minimum. So we know that 30-visit minimum must be authorized when plans determine medical necessity for the new services, but does this 30-visit minimum occur at each subsequent concurrent review?
Yep, so anytime a plan is providing authorization for a concurrent review request, they would have to give a minimum of 30 days. Or 30 visits, I'm sorry. Not 30 days, 30 visits. Visits.
Which don't have to be completed within 30 days.
Exactly. Sorry, I will be careful of my terminology.
So we're just going to take, again, an additional second just to scroll through some of these questions that were coming in and just to make sure that we've answered what we could.
And just to note, we have a lot of questions here that we're sorting through that are related to HCBS that we're really not addressing in today's webinar because the focus is really on the 3 services going live. So unless that HCBS question is related to the services, it's not that we're ignoring you, it's just that we are trying to keep this focus today on the 3 January services.
If an agency is not ready to provide services in January and is taken off the list of designated providers, what would be the reapplication process?
So the reapplication process involves going into your application and requesting an unlock so that you can then resubmit your application with that attestation that would indicate that you are ready to provide services, and then the provider designation review team from all of the agencies would re-review the application, and then we could make a determination and send out a new designation letter. And in the cases of the providers who are being de-designated, since all of their information is there, unless they were making changes to the services that they're applying for or the sites in which the services are provided.
Or changing their readiness.
Well, we would really be looking, is what I was going to say, is that we would be looking at the readiness portion of the application. And so if everything else was the same, our focus would really be on that readiness portion. So we think that we could very quickly redesignate people who are de-designated.
And just as a recommendation, if you are asked to unlock your application, once you have finished making the changes that you want to make in the application, and that you press the submit button and have resubmitted, I would also just recommend that you send an email to the OMH provider designation mailbox to just notify people that that you've resubmitted and that you'd like your application to be reconsidered.
Sure, that doesn't hurt.
If we have an intensive in-home worker who is not a licensed practitioner of the healing arts, who is working with an HCBS client currently, can they make the recommendation to their supervisor, who is an LMHC, to sign off on this recommendation?
Right. So I just want to be clear that when an LPHA is making a recommendation, they're signing off on the recommendation, they're providing their NPI number, and they're attesting to the clinical needs of the child based on their knowledge and their assessment or their or understanding of the client. If that practitioner doesn't know the client, hasn't worked with the client, I would be wary to think that any licensed practitioner would sign something or put their NPI number on something that they didn't conduct themselves. So it might be that the intensive in-home person is utilizing their supervisor to make the recommendation. However, it's likely that that supervisor would still like to meet with the child, assess the child, conduct an assessment to discern whether they meet the medical necessity criteria and are appropriate for the service, and then sign off on the LPHA recommendation, because again, it's their signature and their NPI number that is being connected to that document, and so they really need to assure that they're doing their due diligence in accordance with their licensure.
Thank you, Meredith. I just want to thank everyone for joining us. We've really come to the end of the webinar. We've had a number of questions, and again, we're, as Alyssa had mentioned earlier, there will be additional guidance forthcoming regarding off-site. I also want to encourage folks, if they have any additional questions, you can look at our website and look under our FAQs, and you'll find some of the answers to frequently asked questions there. Again, we want to encourage you to look through the resources that is provided at the end of this presentation, and if you have, again, any other questions, there are some mailboxes that you may be able to send information to as well as our website. With that, we just want to, again, thank you for joining us and want to tell you to have a good day. Thank you.